we start, a bit of a shout out to Sharon for inviting us to speak, inviting the people from the country in Queensland to come down. Saw some traffic lights the other day, it was quite exciting. And also people in Prince Charles have been asked to give a kiss to Manisha Toole, wherever the camera is. There you go. So, Towards an Unbreakable Heart is a good title, and I'm going to talk a little bit about it, but probably not too much. And it's great, congratulations to Sharon and the gang for getting this. The whole key to, I think, all of this is to have as many people collaborating as possible. We started this after we started the Bible Corps programme with Daniel Timms. We realised there were so many good people kicking around Queensland, Sydney, Victoria and the rest, so we wanted to try and get people to put their skills together, which I guess is what's happening here today. And we put in to create a Centre for Research Excellence. So we started, as most good things do, in Queensland with our research group, and then we came down the country intellectually and geographically to involve. Shall I leave now? To involve Sydney and Victoria. And then bit by bit we realised that there's so many people across there. This is the Asian century. So we started to try and develop links across the whole of Asia, and then moving into Europe in the high country of Scotland, and then even across to Trump country where they hadn't built the walls to intellectualisation yet. So bit by bit we've really tried to get the best and the brightest around this, and already this year we've just come out with this 900-page heavyweight thing that my students are using to keep up their computers, and I don't think they've opened them, but it's a nice book there's a plug. Another piece that's come out of this nicely is using open source data. There's a huge amount of research that gets wasted, and the engineers are actually now looking at using open source, so basically free data sharing across the globe in terms of mechanical support. So that's a plug for them as well, Open Heart Project, trying to look at developing mechanical support for areas that are less well off, which I think is a great idea. So not going to go through this. You guys are lucky. The heart and circulatory disorders is the yellow ball, and it's bigger than anything else combined, and that ball is going to get bigger and bigger and more costly. We're interested in mechanical support, both the total artificial heart but also ventricular assist devices too. We started really backwards. We started with the total artificial heart with Daniel Timms and the BiVACOR programme, but do a lot of work in LVAD work. So I guess initially we started thinking, or the VAD community, not us, started thinking of molecular mimicry. The heart beats, and if you look at it across biology, the bird's wings beat too. So therefore the initial cardiac devices followed the concept we should have a beating mechanical device. Leonardo followed that with the beating wings of the artificial bird, the plane, and that didn't go so well. So we probably don't actually need molecular mimicry, because if you flew down in a plane with flapping wings, you should probably take the train back up. And the mechanical pumps now are without pulse, and yet people still seem to survive. So the pulse, and if you think about it at the capillary level where the mitochondria receive the oxygen, that's the whole purpose of the heart, there is no pulse in the microvasculature. But there probably is a benefit, and we'll talk about that a little bit later on. Mechanical support, does it really work? Well, it's pretty obvious. The New England Journal looked at best medical treatment for end-stage heart failure versus the pulsatile devices and showed quite categorically that mechanical support in terms of the pulsatile VADs improved outcome versus best medical care. But best medical care, to be honest, isn't actually that good. So is it really the best? Because surely the heart transplant's better, still, because the heart transplant is the gold standard. And it doesn't look like it's actually that far ahead. Already in 2014, 1 year LVAD survival met or exceeded that of heart transplant, and that is the gold standard as accepted by everyone. And now there are more LVADs than there are heart transplants. And part of that's because if you're waiting for a heart transplant and nothing comes up, there's an LVAD on the shelf, and you can take that LVAD before they develop renal failure, respiratory failure, cardiac failure, and the likes. So as the device, which is still an imperfect technology, gets better, then we're going to see more and more LVADs and more devices. Now, is it going to be implantable pumps in the heart, or is it going to be the smaller devices? It's unclear, because there's a vast array of different types of pumps for short-term and long-term, and you've seen some of them outside. And I'll not go through them too much, but they're getting smaller and smaller. You see the Impella outside as well, very short-term support, but pretty exciting, and there's some other work going in that area. In terms of the duration, some of the devices have been used for up to 10 and 15 years. So if you're 60 or 70 and there is no heart transplant available, this really is a godsend to you. In terms of how it goes in, this is from the left ventricle of a Heartware pump. It's a centrifugal pump. It's continuous flow. It's about 160, 200 grams, and it can give up to 10 litres flow. So lots and lots of flow, and more than adequate for the needs of our patients. This is the HeartMate 3, which is probably the gold standard, and we'll talk about a couple of the New England Journal studies that Dr. Vallely was so derogatory about just before, and we'll talk a little bit about the benefits there. When to implant them, the VADs are implanted really with, and this was a fairly strict criteria that was developed many years ago and probably is less relevant now, bridge to transplant, destination, bridge to candidacy and bridge to recovery, and I'm certain Paul Forrest and myself and others think that on the recovery side of things, mechanical support with ECMO is probably more efficacious, lower mortality and easier to do. So the bridge to recovery, at least our decision making when people are post-cardiac arrest, is definitely not VADs. The problem with the VAD intent is it was a long time ago it was created. The data now doesn't actually support the intent concept because the numbers are changing dramatically. So these have relatively been abandoned, and the decision is now based on presence of indications and absence of contraindications because the devices have got better, our patients have got sicker, and we can see patients do a lot better. So this is the hardware. This is how it sutures in. There's a sewing ring, and that's tricky. Speak to our surgical colleagues. It can be, if you imagine an infarcted apex, it's like sewing a suture ring into a wet piece of tracing paper, and it oozes and bleeds, and they swear a lot and call it anaesthetic bleeding. Never quite understood that when you cut a sternum open, that's the anaesthetist that causes it, but there you go. Michael will have an answer for that, I'm sure. That's the hardware in position. I apologise to Greg Scally, I put this up and then I've just realised I've nicked it from David McGiffin. It's not an Alfred tool. Greg does more than beautiful echoes. I just don't know quite why I've not got one of his. So apologies for that one. So we can use it in the left ventricle, but the right ventricle still is the second most important ventricle. So we're looking at, we can't just support the left ventricle because it doesn't work. So at the moment we don't have a total artificial heart. We'll talk about this. But we've got biventricular support with 2 LVADs. Problem is the LVADs were developed for the left ventricle, the systemic pressures, etc. So we need to somehow make them work off-label and against different pressure beds and work on how we correlate the two, because it's a little bit like driving from Brisbane to Sydney on 2 motorbikes and keeping the wheels exactly aligned the whole way down. One goes too far ahead of the other, there's big problems, or vice versa. So the question is, how do we do that, and how do we get the two to correlate? And this is some of the research by Michael Stevens from our lab, but also now based in Sydney. And looking at it works nicely for left ventricular failure, as we've talked about. But what about right ventricular failure? And we've started using these. If the pulmonary flow gets ahead of the systemic, you get pulmonary venous congestion and RV suction. If you get systemic flow ahead, you get systemic venous congestion, LV suction and hemolysis. So it's bigly problematic. Equally, the clinician's not there the whole time to fix it, even if they knew how to fix it. They're not always there. We want this to get patients back to their house, to the children, to their family, to their jobs. So we need to have an automated control system, a smart cruise control, if you like, so that the bikes don't crash on the way down from Brisbane. So the question is it 2 cats hand in hand, or is always one ahead of the other? They've called it master and slave, which I thought was interesting. This is in our lab, at the ICET lab at Prince Charles. This never looks as tidy as this. There's normally spillage of glycerol everywhere. But this is what an engineer thinks a heart looks like. And really, Michael did some beautiful work looking at master-slave and showing, and I'll not go around it for long, but the master-slave relationship here works much, much better. There's much less problems, and the LVADP we want to keep below 25 is much, much better than the master-slave relationship. In terms of the ventricular work, there's much, much less weight put on the recovering left ventricle if we have a master-slave relationship. So currently, this is an area in development. Pulse, we've talked about. Do we need it? We know there's benefits of the pulsatile flow. The aortic valve opens nicely, there's reduced GI bleeding, but the survival rates are worse. They need a pneumatic drive, and that's complicated. Continuous better outcomes, but we lose the valvular function, we get increased bleeding, and question about whether the LV develops thrombus in it. This is some work from one of our other PhDs looking, this is the heart failure models, we get MRIs, print the heart, make it into silicon, and then we put this in the loop and look at the flow dynamics. And fresh blood is, if you imagine, blue, and red is more clotted old blood. So we can find out in the pulsatile versus the continuous that there is more old blood, so there isn't as good left ventricular washout. It's great to keep them alive, but if you give them a stroke, they're not going to thank you for it. We can put pulsatile different waveforms into it, but equally, there is a benefit of having a pulse to allow that washout, but we've also shown that there's increased risk to red cells. So the jury's still out, really, in is it totally the right way to go? In terms of total artificial heart, the Syncardia was developed, and there's been 1,300 implants. It's a big, big piece of kit with a pneumatic drive, either the size of a washing machine or a very heavy backpack. The Abial core was, just didn't work and was way too big. Carmat is being developed in France, but with limited success. And the drivers are a big component. This is, as I say, the size of a washing machine. They're getting smaller and they're getting on backpacks, but I think this guy's 7 foot. And this is a 32-year-old. If you're from Scotland. The total artificial hearts, the Cleveland heart, and the Bivacor, and I was involved in Bivacor as a conflict of interest. But it's now based in the States, but it's got work with Chris Hayward here, McGiffin up down in Melbourne, and ourselves up in Brisbane. Third generation with zero mechanical wear, and it flow balances nicely, and Greg Scallow is involved in helping us at the start of this. If the video works, this is how the device works. It's got magnets, 16 magnets around the base and some axial magnets, and it works as left and right ventricles, so right and left, if you imagine. Blood flows into the right at the top, out to the lungs, a central disc with impellers on either side, goes to the left side and goes out. Again, this is all Daniel Tim's work, who worked with us there. The blades are different size, getting away from the problem of using an LVAD on the right side. We can make the blade size difference to deal with the pulmonary pressures versus the systemic side. There's a washout built in within here so that there's actually a deliberate leak, as can be seen in some of your valves. And because it's a dynamic situation, the impeller can move more to the left or more to the right, depending, when using it as an assist, a biventricular assist, depending on which ventricle needs more help. And it can either implant as an assist, or we can remove the heart and use it as a total artificial heart. Other areas that we're working on and that need to be done is looking at the infection of a ventricular assist driveline. Basically, that's the last happy day that patient's ever going to have in life. If you imagine how often we change drips and central lines, this has got a percutaneous wire going across the chest for 10 or 15 years. And once you get a driveline infection, it's a disaster. So we're doing some tissue engineering here, along here. What will come next eventually will be TET, transcutaneous energy transfer. So we get rid of the driveline, the patient's enclosed, and it actually means he can go for a swim, go for a shower without having to protect this whole area. Flow balancing, again, is an important area, trying to work out the optimal flows across this. And again, our engineers do this so that you get less rhythm disturbance, less ventricular suck down, but also when you're lying in bed, you don't need 11 litres flow. And you talk to the patients, you say it's like having 2 cans of Red Bull. You just sit looking at the ceiling because you get 11 litres pumping out continuously. Is this the future? Are we just talking about things that are not really there? I don't think so. 2 England Journal papers, basically hardware, which is centrifugal, versus the HeartMate 2, which is axial. And what you saw was the HeartMate 2 had more devices. It's axial, it causes more blood damage. The hardware, however, had more strokes. And then in the same journal, or just subsequently afterwards, it was HeartMate 2 versus HeartMate 3. HeartMate 3 versus HeartMate 2 is a centrifugal, so magnetic levitation pump. And that showed quite nicely. It worked as well, but had much less of device risk. So the least strokes and the least device malfunctions. So that's the take-home message for there. One of the areas we're working in is putting LVADs. So we've got sheep that we've infarcted, developing ischemic cardiomyopathy, mitral regurgitation, putting valves in, and then to try and regrow the heart with cardiomyocytes. So eventually we can take the VAD out. A lot of work from a lot of people. I'm not claiming any of it. And I think the key is to move forward together, as you guys are doing here. Thank you.